Hi there. Sorry for the little bit of confusion. Good evening. Thank you for your patience and taking time away from evening activities. First reminder is that if there are any questions, send it to the question and answer segment. And one of my PAs and nurses, Maggie and Amanda, will be available to answer questions as they come in. And if there's something especially either interesting or difficult, I'll answer them after we're done. This webinar is recorded, and tomorrow we'll send you an email with the link. So tonight we're going to talk about traumatic anterior shoulder dislocations. The purpose for this talk is to kind of give generalized information, and then also to share with the world a relatively novel technique. I'm not the only one doing it, but there aren't very many people doing this for a particular type of shoulder that is dislocated many times and has significant bone loss. And we'll kind of go through a neat arthroscopic procedure at the end of this talk. So the hip or the shoulder is an inherently unstable joint. And compare the most stable joint, which is the hip joint, which basically is a ball and socket, compared to this very flat shoulder joint and ball, kind of like a golf ball on a tee. The bony stability is very limited in the shoulder versus in the hip, it's quite strong. Both joints have ligaments that hold things in place. The shoulder's ligaments are dramatically more important than the ligaments about the hip. The shoulder joint is a shallow ball and socket joint. The shoulder itself, the whole girdle, is comprised of the clavicle, the shoulder blade, and the humerus. The primary stabilizer of the shoulder, though, as we saw in the pictures, are not the bones. It's the labrum, which is a cartilage rim that you can kind of see on this picture that goes around the cup. It's circumferential. It's soft, allowing the shoulder to kind of go everywhere, but its job is to provide more surface area, about 30%, to the cup, acting like a little bit of a suction cup. What comes off the labrum, as you can see in this middle picture, is the capsule or the ligaments. And there are certain thick folds that we call ligaments, but basically it's a bag that holds the shoulder in place, lubricates the shoulder, and nourishes cartilage by the fluid it makes. The secondary stabilizers of the shoulder are the rotator cuff muscles and tendons, as you can see in this last picture. And there are 4 tendons, one in front, one on top, and 2 in the back that attach in an upside down U, and their job's to hold things in place. If either are deficient, ligaments, labrum, or muscles, we can have an unstable shoulder. The shoulder comes out many different directions. Anterior, or out the front, is the greatest or most common dislocation direction, and about 90% of all dislocations. Posterior, or behind the shoulder, is sort of second. Very rare is the inferior dislocation where the ball goes below the socket. There's a terminology in shoulder instability of subluxation versus dislocation, and thinking about this, subluxation is slipping of the shoulder, not quite coming out, and dislocation is that frank coming out of the entire cup of the ball. How common is anterior shoulder dislocation? About 1.7% in the general population dislocates their shoulder. Anterior dislocations make up 45% of all dislocations, and nearly 50% are in that young age group from 15 to 29. They're also the riskier group for repair or treatment. The risk factors in this are genetics, laxity. Similar to eye color and hair color, people are made with looser ligaments on sort of that typical bell curve as far as how tight or how loose you are. Younger age is more common and more risky, mostly because the younger you are, the more adventurous you are, the bigger you go, the greater chance of potentially getting hurt. And of course, just like other things, males are a greater risk for dislocation than females. And then it really depends on the activity. The more contact the sport is, football, rugby, Australian rules football, lacrosse, things like that, the greater the chance of dislocation compared to a less contact sport. How does it happen? Again, contact sports, running into people, trying to tackle people, or a fall. And anterior dislocation usually happens with the arm in that throwing position. Abduction is the arm here. External rotation is the arm back here. And that's the most common way to stress the shoulder to come out the front. It can happen in a motor vehicle accident, but most common are either in sports or falling, such as our snowboarders, skiers, falling off your bike, etc. People with a seizure disorder can also have such a vigorous contraction of their muscles that they can have their shoulder come out, or they seize and fall and the shoulder can dislocate in that fashion as well. What structures can be damaged? Many. We have the labrum, which tears, and it tears off the front, creating a tear of the ligaments. The ligaments are attached to the labrum. The joint capsule itself can also tear as a secondary disruption of that cartilage or the ligament complex. The glenoid or the cup can be damaged, and as the ball comes out, it can take bone with it, or the number of times you come out can rub it or wear the bone down. The humerus also can sustain a fracture or injury, and that can happen on the way out, on the way in. As it tries to come back out, there are many different types of injuries to the bone. The older we are, mostly over 40, our rotator cuff tends to be stiffer than the ligaments and tends to run into more trouble. There's a particular nerve that kind of runs right underneath the cup called the axillary nerve. It provides sensation to the outside of the shoulder and motor or power to the deltoid muscle, and that can get stretched in this dislocation. It's very rare unless it's an extremely severe dislocation where the humerus, this part, goes way up under the clavicle, that blood vessels are damaged. Damage to the glenoid can take a soft tissue component, or it can take a bony component. If we look at this first picture, this is the labrum. It's that cartilage rim that goes around the cup, providing that excess surface area. What we also can see is one of the two biceps tendons begins at the top of the glenoid or the cup, and that can also tear. As you dislocate out the front, it can peel that top labrum down, and that we call a slap tear. Slap is a name for superior labrum, or the top of the labrum, anterior posterior, or front and back of the biceps anchor. And that's susceptible to injury and a dislocation, again, more often in the younger age group. But this is the Bankart lesion, which is another name for the tearing of the labrum from the cup. We can have a fracture, as you see on both of these x-rays, that as the ball comes out, it strikes the glenoid and breaks a piece of bone off, and the bone comes away with the ligaments. This is inherently much more unstable than just the ligament damage, because not only now do you have ligaments torn, but the surface area of the cup has been diminished, and so there's less for the ball to stay on. Think about a tee that's broken and trying to get your golf ball to stay on it compared to a whole tee, which is easier for the ball to stay on. The rotator cuff, about 17% of dislocations, you tear your rotator cuff, and that can happen at all age groups, but it's much more common in all of us over 40. It's because the rotator cuff tendons are less flexible or rubbery compared to the labrum, and so you can tear that rotator cuff. Most kids who dislocate and get put back into place, their pain dissipates pretty quickly, whereas someone has torn their rotator cuff anywhere 3 to 7 days down the line. If they're still in a lot of pain and weak, more than likely they've torn their rotator cuff in this injury. When we look at damage to the humerus, the most common is this lesion called Hill-Sachs, two different surgeons that described an indentation fracture of the humerus. So think about that styrofoam ball that you stick your thumb in and leave an imprint. What happens when the humerus comes out, the top back of the ball strikes the cup, and you can get an indentation fracture of this soft, spongy bone, and that's called a Hill-Sachs lesion. And it can happen in a very large variety, like these two CT scan and X-rays, or it can be small enough that's just a scuffing kind of injury. The bigger that Hill-Sachs lesion is, though, if it's big enough, all you have to do is rotate, fall into that Hill-Sachs lesion, and you can redislocate. So it's important in ascertaining risk of further dislocation and kind of the extent of injury to that particular patient. Other fractures that can happen are the greater tuberosity, and that's where the rotator cuff is attached. That's kind of a bigger Hill-Sachs lesion, most often in osteoporosis or people with weaker bone. Also, you can have four-part proximal humerus fractures. And why this picture is not coming up, I'm not sure, but this is a picture of a four-part proximal humerus fracture that happens again in that same dislocation. This strikes the cup on the way out and in, can fracture this portion. The rotator cuff, again, being stiff, can pull on this as the shoulder comes out, and the bone gives way instead of the tendon or the ligaments. The damage to the capsule or ligaments, again, these are discrete thickenings of this whole lining, and you can tear most commonly this anterior band of the inferior glenohumeral ligament, and that comes off the cup most likely. Occasionally, rarer, that ligament tears from the humerus, and a lot of times what we don't see here is the front rotator cuff tendon, and that can come off with the ligaments, and that's called a Hagel lesion or humeral avulsion of the glenohumeral ligaments. That usually comes off the humeral head. It can happen in the front. It can happen underneath. And that's a very difficult fix. And the most common, again, is off of the cup or that anterior inferior glenohumeral ligament lesion. So you've dislocated your shoulder. Now what? Well, the number one priority is to put that shoulder back in place. And a lot of times this happens on the ski mountain, out on the mountain bike trail. And if you're not adept at reducing this fracture or this dislocation, or it's not happened before, then kind of roping your arm to your side, holding it in as still as possible, and getting medical help, whether that's to the ski patrol or to the emergency room, so that it can be put back in place, is key. At that medical environment, we'll do a physical exam looking at nerve injuries, and most often an X-ray is taken when you're out to, if it's not obvious, which a lot of times it is, which direction it's come. Is it front? Is it back? MRIs and CTs are usually reserved for surgical decisions and to look for other secondary injuries. These dislocations can be treated a couple different ways, and depends on age, depends on what you do with yourself and the risk factors. So those risk factors can be fractures, can be tears, anything that's added to the frank dislocation can change this from something that can be rehabbed or fixed. And it really depends on age, sport, etc. The conservative treatment is first to quiet down the discomfort and pain, reestablish safe, pain-free, stable range of motion, and then your strength. And that strength isn't just the individual muscle groups, but it's also that coordination of the shoulder. We used to think that coordination of any joint or body was God-given, and that was it. Well, we know that if we can train a joint to know where it's at in space, have the muscles fire on time and quickly, we can provide a dynamic stability to that shoulder. And so it's first strength, and then it's teach those muscles to fire on time, and kind of that push you, pull me, so that when you go in one direction, the other muscles are pushing in the other direction to hold you in place, therefore getting the stability. And this can happen fairly quickly, depending on age, depending on other damage in the shoulder. Who needs surgery after that shoulder dislocation? Well, we can't get you back in place. Pretty uncommon. A lot of times that's a fracture that's bigger than we think, or soft tissues in the way. But more often, it's just that we can't get patients to relax their muscles well enough to dislocate them. So when I get called in for a dislocation that the emergency room doctor can't put in place, usually a general anesthetic with complete muscle relaxation allows us to get it into place. When we look at another indication for surgery, it's a recurrent dislocation. If we look at statistics in that 15 to 25-year-old age group, first-time dislocation gives you about a 70% to 80% chance of redislocation. Second-time dislocation is a 100% chance of redislocating. So we usually use a pretty absolute indication for surgery as 2 or more dislocations. Bone loss, when we see it, and that's usually seen on plain x-ray, and occasionally we'll need to do a CAT scan or an MRI to look further. But bone loss, around 13% of that surface area of the cup in that high demand population. So wrestlers, football players, kayakers whose paddle is up and out of place. Those people don't need much bone loss to have a very risky shoulder for redislocation. So surgery and dealing with that bone loss is the indication for taking care of them. If we see more than 25% of the humeral head indented, then that's also another indication to either repair that bony defect or treat the shoulder in a way that keeps that bony defect out of the picture as far as creating instability. There's a common sort of statement these days of off track, on track, and it really is about bone damage on both sides. So when the glenoid or the cup defect engages with the humeral defect, that arm can be very unstable, increases their likelihood of dislocation. And so it tells us that we are more apt to have success with repair. Again, depending on this off-track, on-track lesion, meaning the size of both defects combined, we may need to do something more than just repair those torn ligaments. We may need to add bone, we may need to repair bone to provide better stability. And then displaced fractures of the humerus, such as that greater tuberosity fracture, what's on that tuberosity are the rotator cuff muscles. And so those muscles can pull the bone out of place, which makes the shoulder either more unstable or weak. And then the next is that failure of conservative treatment. So how I manage this, depending on what you want to do with yourself after your shoulder is recovered, is we try to rehab people. And if we can get that shoulder comfortable, moving correctly, stable to sort of those stressful positions, then we can allow you to go back to sport, and you can usually be successful, again, depending on your sport, depending on your age, depending on how lucky you are. If we can't get you there, my shoulder still feels loose, or boy, every time I go close to this position, I'm afraid, then you're not going to get there after a certain period of time, and repair is going to have much better results for a comfortable, stable feeling shoulder than further treatment in a conservative fashion. If we look at considerations for surgery in young athletes, we know that about somewhere around 70% of shoulders redislocate without surgical stabilization in that less than 18-year-old age group. And we also know that early arthroscopic stabilization significantly reduces that recurrence rate when compared with non-surgical treatment. And if we want to look at gross statistics, and it's somewhere between redislocation rate without fixation, somewhere 60 to 90%, and with repair after first-time dislocation brings it down under 8% chance of redislocation. We know that athletes who are treated non-operatively can experience a recurrence, again, depending on sport, in the next season. And then that young athletic patient with history of multiple dislocations before stabilization have a greater risk of post-operative instability when compared with that patient having surgery after their first dislocation. We think that's because those ligaments have torn more, we've lost bone, and so we therefore have not just ligament damage, but we don't have the surface area for the ball to stay in place. And so that patient that's come out many times, unless we take into consideration the extra damage, they will redislocate more commonly than that person who's come out just once and may not have the humerus or cup damage. So what do athletes want to know? athletes are significantly more likely to return to play successfully without instability events if they undergo a surgical repair in the off season. Again, that's 60% with best thoughts to 90% redislocation rate without repair versus under 8%. The goals of surgical treatment, number one, is repair that damaged and torn tissue back to a better place. Our bodies and our ligaments are elastic in nature, and so it's not just putting the ligament back where we think it was, but it's actually taking up the slack from that stretched out joint, and that ideally prevents future instability. The other part of preventing future instability is understanding the injury pattern. What else is damaged? Is it ligaments, or are there bone as well, or are there tendons that are damaged? And taking care of all of that at the time of repair. A long time ago, we used to think that just repairing the ligaments was enough, and we're much smarter at providing stability to a shoulder by really taking into consideration all of the possibilities of further damage. By reducing things and getting things stable, we will decrease pain, and obviously, if you have a stable shoulder, we will improve your function. So common surgery with no bone loss, whether it's a humerus lesion on the humerus or a lesion on the cup, is to do a labral repair. This can be done open, or more commonly, and probably most common in shoulder surgeons, is to do it arthroscopically, and that's a repair of the labrum. We prepare the bone, we put anchors in the bone that are either absorbable plastic or suture, and they're tiny, about 1.8 millimeters in size. And then the suture's wrapped around the labrum ligament complex, because this isn't isolated. The ligaments are attached to the labrum, and sew it back to where it belongs. Again, taking consideration of the slack that's created by multiple or one-time dislocation stretching the tissue. This can be quite successful, again, in the right person, complex, meaning what they want to do with themselves. They're not a contact athlete, don't have bone loss, etc. With bone loss, namely this Hill-Sachs lesion in the back, again, if you rotate enough, that Hill-Sachs lesion can engage with the front of the cup and make it more unstable. And so in that shoulder with a Hill-Sachs lesion that engages, meaning I can push it and rotate it and it comes closer over the edge, we'll do that same labral repair with a procedure called a remplissage. And by remplissage, what we do is we take the back capsule, sew it into the bone so that it's occupying the space of that hole, so that when you rotate, the ball doesn't fall into the cup because that soft tissue's in the way. And we know that we can dramatically improve redislocation rates and return to sport rates with the remplissage plus the labral repair, somewhere around 5%, versus a labral repair alone has around a 15% redislocation rate and return to sport rate. When there's enough bone missing, and that's either a one-time dislocation or more commonly in that kid, mostly a guy, who's dislocated many times. And we've taken care of people who've had 40 or 50 dislocations, and they're finally tired and sick of dislocating, or it's so easy to dislocate that they dislocate sleeping and doing basic activities of daily life, like just relaxing and putting their hand up, and they can't, and they come out. We'll need to replace that bone, and it's done a couple different ways. Depending on size, we can take a portion of the coracoid, which is this bone, there's a tendon attached to it, and we can place that in the front of the cup, holding it in place with screws or special wires or anchors that are sutures and buttons. And this is a tried and true method, very commonly done in Europe as primary surgery, or in the US in bone loss or high-risk patients. This, in my hands, is done open. There is an arthroscopic technique that is a very steep learning curve, but is quite successful to hold the bone, the shoulder stable. By placing the bone, we've created increased surface area, so less likely for things to come out. By placing the bone and this tendon, we create a special sling that's dynamic, when the arm's in this position, not only is the bone there to protect things from coming out, but now you have this extra tendon coming across the joint. This surgery done arthroscopically, there's a fair amount of neurologic structures that are at risk, and the learning curve, like I said, is quite steep. What I've chosen to do is learn a different arthroscopic procedure that doesn't incorporate this tendon, nor do I take anything from the rest of the body, and we put in a block of bone. And that can be with an allograft, meaning a cadaver piece of bone, or more commonly, the way I do things is I take about 2 centimeters of the end of the collarbone, which is not very essential, and put it into the cup, sewing it in place or holding it in place with either a special suture construct or buttons and special sutures or even screws, and then repair the ligaments over this, providing that bony surface area. And the bony surface area makes it harder to come out because there's more bone to go by. And when the ball rotates, if there's a big Hill-Sachs lesion, it hits that bone as opposed to coming to an edge and coming out. So this kind of bone block procedure can reestablish the surface area of the cup, and it can make it a lot harder for the ball to come out because of the humeral side lesion. So this is a video that kind of goes over the repair. And so here's treating the bone. We get it prepared. We pull special sutures into place. And I've already harvested the end of the collarbone that's prepared. And then we can kind of move along a little bit. This is just, again, special ligament structure. We pull that, oops. Sorry, this is kind of not going the way I want it to, but we pull this piece of bone in place, tie it into place with the 2 different forms of anchoring systems. And then what we'll do afterwards is we then repair the ligaments over the top of it. And so we make this bone block extra articular or outside the joint. And so now we have the surface area from the bone block and we have the ligament structure. This is safer than taking this portion. The risk to nerves is much less. The learning curve is still fairly steep and it takes a bit of experience to do, but this is something that we're doing here and I've had very good success with. We started using cadaver bone that was very easy out of a bank, and that worked for stability, but it didn't really heal into the people's bone. And so therefore we've gone to using our own bone, and depending on the size of bone needed, the end of the collarbone works very well, or taking a portion of your iliac crest or the top of your pelvis when it's really a ton of bone loss. And then occasionally we can go to a cadaver piece of bone that's placed in that has cartilage to it. This is less expensive using your own material that you're more likely to incorporate. When we have a fracture on top of the instability, we'll fix the fracture, and that provides the stability to the joint. So if we break the greater tuberosity, a plate and screws to put things back in place and to anchor the rotator cuff in place can be very beneficial, and the redislocation rate after this kind of repair is minimal. When it's more parts to the bone that are broken, we end up having to do a form of shoulder replacement to provide stability and function to the shoulder and get it to heal. This is a reverse shoulder replacement that is for that special fracture that's in 4 pieces or more. And this is in that older age group, 65 plus. Most often when this is broken, the humerus in many places. So thank you very much for your time and attention. Hopefully we've answered a fair amount of questions, and Amanda or Maggie will bring other questions to me. Want you to know that Dr. O'Connor, who's our total joint specialist, will be doing a talk on April 3rd about advances and knee replacement surgery. Please tune in for that. He's a super guy and has a lot of really cool and wonderful information to impart.
All right, so I am going to just stop this share so everybody can see your face while we ask you questions. So got a few questions for you. First one, is it worthwhile to try to have my untrained friend try to relocate my shoulder immediately after the injury? Is there any benefit to that or only risk of further injury?
So it depends on age and depends on how many times you've come out. Probably if you're a long ways out, being familiar with wilderness first aid techniques and reducing the shoulder just makes the transport out a lot easier, a lot safer, but always err on the side of not doing anything till you have an x-ray and a good exam so you don't make things worse. But certainly if it's hours till you get out, a gentle reduction attempt and inform yourself on how to do that. There's a lot of really good videos on how to do that. Can be a great benefit for that patient. Certainly our ski patrolmen can reduce shoulders, and they a lot of times before they bring you down in the toboggan, depending again on what they find and see, will put you back in place.
Great. So if I've dislocated my shoulder and then I feel fine, can I just return to my normal activities without any treatment, or should I?
So, ideally, this again is not trying to push medical people, but if you've come out and you come back in and you're feeling great, that shoulder joint still has injured its ability to sense where it's at in space. And so to make you better, it's a great idea to teach your shoulder how to stay in place, how to dynamically help itself. And that's just a bit of exercise. It might take 1 or 2 visits to a physical therapist or our athletic trainers giving you an exercise program that teaches you that dynamic stability that gives that shoulder that feels good an even better opportunity to not redislocate.
So a couple questions kind of expanding on that. What is the reasoning behind early movement and physical therapy versus waiting, giving it a chance to rest?
So we used to think that 6 weeks in a sling would heal these ligaments and you'd have a smaller chance of redislocating. There have been numerous studies showing that sling use, either being very diligent or not, leads to either a stiff shoulder or one that dislocates just as easy as one that was moved right away. There's one study out of Japan where they put patients in a cast that held them way out here, and they had 0 dislocations after that. That's never been able to be reproduced, and in this country, none of us are going to use that splint or brace effectively. And so it's very hard to immobilize the shoulder in the right way for the ligaments to heal. So my preference is to get people carefully moving, not going into the risky places of movement, to allow the shoulder to heal itself, to improve upon pain, to improve upon comfort. If you just sit and allow yourself to heal, some people can get extremely stiff because of the inflammation, and that stiffness can create a condition called frozen shoulder adhesive capsulitis, and that can be very, very painful and difficult to get back from. So we know by lots of research and studies that moving people, getting people to dynamically hold their shoulder in place works much, much better than just sitting in this.
If there are no breaks or tears, just stretched ligaments, can rehabbing strengthen the shoulder enough to avoid surgery?
Absolutely. There's, again, depending on age, depending on sport and activity level, if you can regain comfort in those unsafe places. So if I take you this place and you don't feel any worry or any fear, then we know that we can probably keep you from redislocating. Much better success 30 plus than 15 to 25, but certainly rehab can be the only treatment after a first-time dislocation. But that sort of depends on what's damaged, depends also on the sports you participate
in. 2 more questions.
Sure.
Next one, what are the top 3 rehab activities to do 1 year post bony Bankart repair?
Rehab activities. Well, ideally at a year, you should be very well rehabbed. But if you're still deficient, it's again gaining strength in all four of the rotator cuff muscles. And then most importantly, besides strengthen those muscles, is to coordinate that strength. So it's balance kind of work. It's a one-arm plank. It's a sort of leaning on a ball. It's a throwing motion where you're catching the ball and stopping things quick enough. And so there's a lot of educational things that can be done to your muscles to teach them to fire on time and in a coordinated fashion to keep you in place.
Okay, last question for you. Does experiencing a subluxation of the shoulder increase one's risk of dislocation?
No, not necessarily. If you have that loose shoulder and you're on that loose end of the bell curve and your shoulder is slipping after an injury, again, those muscles aren't firing on time, aren't keeping you in place. And so we do know that that hyperlax person has a greater chance, but if we can teach that shoulder to be stable again, then no, your risk is not dramatically increased by just slipping.
Great. That is all of our questions for tonight.
Well, thank you, everyone. I appreciate your time and efforts. And again, April 3rd, Dr. O'Connor advances in knee replacement surgery.
Stop video mute.